All right, so now we're going to look at schizophrenia spectrum disorder and psychosis and the manifestations that go along with that. So we're going to talk about the different psychotic disorders, the risk factors, what it's going to look like, how we treat it, and how we use clinical judgment while treating it. So on this one, we're just going to talk about different psychotic disorders. So the main one that comes to mind when you think of psychosis is schizophrenia. This is going to have those psychotic behaviors such as delusion and all that we're going to talk about later. That's going to be present for about 6 months or more, and it's going to impact their daily functioning in life. Schizotypal personality disorder is a type of personality disorder that has schizophrenic traits. So we are going to table that discussion for when we talk about personality disorders. We have delusional disorder, which is where you have delusional thoughts of grandiose, persecutory, somatic, or referential themes, but they do not impair function, and they last about a month or longer. Okay. We have brief psychotic disorder, is just what it sounds like. Psychosis, delusions, hallucinations, disorganized speech, being disorganized or catatonic in behavior, and having these manifestations, but instead of lasting 6 months, they last a day, anywhere between 1 day and 1 month. We have schizoaffective disorder, and this is where somebody meets criteria for schizophrenia, but they also have either bipolar or depressive characteristics. So that's a combo of depression and bipolar with the schizophrenia. And then substance-induced psychotic disorder or medical condition. This is a big one that I like to talk about. I know I've talked to y'all about my girl on the psych unit that had encephalopathy, and she was not treated. So, and it led to her downfall, essentially. If a client, so of course, substance induced is when a client experiences psychosis due to substance intoxication or withdrawal. And typically with substance induced, the manifestations are more severe than someone with just schizophrenia. We also need to remember that delusions and hallucinations can come from delirium, neurological diseases, hepatic and renal diseases, and many more. When someone just comes in and displays sudden onset schizophrenia or sudden onset psychosis, we need to rule out medical and substance use first. That's just big. So the exact cause of schizophrenia and psychosis is really unknown, but it is thought to be genetic, meaning passed down, or neurobiological and caused by an abnormal amount of dopamine. Some prenatal stressors may contribute to potential schizophrenia things, along with birth complications, prenatal viral infections, poor maternal nutrition, and exposure to toxins. Big thing is the golden time for onset is early adolescence and late adolescence, early 20s. So that's like typically when that onset happens. So right in that late high school, college years, that's your perfect storm for a schizophrenic break, to have your first set of symptoms occur. So we have symptoms of schizophrenia, and they are characterized by either positive, negative, or cognitive. So I represent these positive and negative with a plus and a minus sign. And the reason is they're not positive and negative as in good or bad. Positive are things that are added that should not be there. And negative is when things that should be there have been taken away. So positive symptoms, this is going to be things that should not be there, like hallucinations, delusions, changes in speech, that bizarre behavior, things like that, like walking backwards, things that a normal, healthy person should not be doing, they are doing. Where negative symptoms are an absence of things that are normally present. This could be things like a blunted affect, that very flat facial expression. Alogia, which is that poverty of thought or speech. They're not really talking, they don't really have thoughts going through, they're just kind of blank stare. We have anergia, which is the lack of energy. Anhedonia, which is the lack of pleasure or joy. We see some of this in depression and stuff as well. We have avalation, which is the lack of motivation. This is when there's lack of hygiene, lack of motivation to do things. Projects are kind of maintain unfinished. They have that lack of motivation to continue in activities. Cognitive findings make it difficult for them to live independently. This can be our distorted thinking, inability to make decisions, and poor problem-solving abilities. This can also be short-term memory defects and impaired abstract thinking. We have lots of feelings of hopelessness and suicidal ideation, so we got to make sure we are looking at that. We also need to make sure we're looking at agnostia. This is the inability to realize that they are sick. So this is a lot of times why when they're in active hallucination, they're not willing to take their medication, or when even if they're starting to get better, they don't take their medication and fall into relapse because they don't believe that they're sick, so they don't need that medication. So that's a big one that we're going to see with these guys. So just knowing the difference between the positive and negative and the cognitive, especially this inability to realize that we're sick. So with schizophrenia, we have things like alterations in thoughts, which is also called delusions. These are false fixed ideas. We can have ideas of reference. This is when somebody misconstrues events and they attach personal significance to them. So this could mean they see somebody talking on TV, but believe that they're talking just to them, that this is about them or for them or towards them. We have persecution, which is where they feel singled out or harmed by people. This is the people that tell you that the government's after them, they're being watched. This is where some paranoia comes in. We have grandeur, which is grand. They think they're the best. Always say they're the grand king. They believe that they're all powerful, important, and very godlike. Okay. We have somatic delusions, which is where they believe their body is changing in unusual ways. This could mean they feel as if their skin is melting, their fingers are falling off, their teeth are falling out, when none of that is happening. We have jealousy. So typically they believe that partners are involved in other sexual encounters even though there's no evidence and it's not factually true. They may feel like they're being controlled, so that they feel like outside forces are controlling them. We have thought broadcasting. This is where they feel like others can read their mind. And thought insertion, where they feel as though somebody is placing thoughts into their head and their thoughts are not really theirs. We have thought withdrawal, and this is where they feel as though their thoughts have been taken away by an outside source. So thought withdrawal and thought broadcasting are pretty much the opposite of each other. One is we're putting the thoughts in there. The other one is we're taking them away. We have our religiosity, which is where they get super obsessed with religious beliefs. And then we have magical thinking, where they believe their actions are able to control a situation or others. This could mean that they feel like if they do something, they can be invisible, or if they do something, they can fly, things like that. We can also have changes within our speech. This can be associative looseness. So this is the inability to concentrate on a single thought, which leads to flight of ideas, where you topic jump. Within one sentence, you talk about 7 topics. We have neologisms. So neo meaning new, logisms meaning words or vocabulary or speech. So this is where they come up with new words. So these are words that are not in a dictionary. They're not even urban slang or anything along those lines. They just make them up, and to them it means something. The best one that I give for this one is Danglehopper from The Little Mermaid. That's what she calls a fork. We have echolia. It starts with echo. This is where they just parrot. They talk back and forth. What you say, they say. They just mimic you. They're not saying their own words. Then we have clang association. This is psychotic rapping. So this is just rhyming. Fox, box, trox, grape, mate. They just rhyme the words that they hear. And then word salad. This is where they take words that are real. They are real words in the English dictionary, but they just throw them together in a way that makes no sense. Mermaid, fish, swim, train, road, fork. So they're just put words together and they think that they're saying a cohesive sentence. We also have perception issues. So this is going to be our hallucinations. This can be auditory, like hearing voices or sounds, and we need to be super careful about command hallucinations. When someone is having an hallucination, the first thing we do is ask them what the hallucinations are, especially if they're verbal, what they are saying, because we need to know if they're telling them to hurt themselves or others. That is a command hallucination. Someone who's having command hallucinations are at a greater risk to hurt themselves and others. So that's something we need to be aware of. We have visual, which is where they see things that aren't there. Olfactory, which is where you smell things that aren't there. Gustatory is taste things that aren't there. And tactile is bodily sensations or feeling things. We talk about this a little bit with alcohol withdrawal. They can get the tingling or a lot of people call them creepy crawlies all over their body, where they're itching or they feel bugs walking on them. That's a tactile hallucination. We'll have some boundary issues. We can have disenfranchisement. We can have with one's own body and perceptions. So depersonalization, which is where they feel that they've lost their identity. They just don't feel like they're themselves. We have derealization, where they feel like the environment has changed, that maybe they feel like Alice in Wonderland syndrome, where things are shrinking or growing that aren't really doing anything. And then we have illusions, which is misperceptions or misinterpretations of a real life experience. So where a hallucination is, I see a snake in the corner, and there is no snake, there is nothing in the corner. A illusion would be, I see a snake on the floor, but what's really on the floor is a pencil, and they're misinterpreting that as a snake. Then we also have sometimes some issues with extreme agitation, such as pacing or rocking. We have stereotype behaviors, so they have, like, they're performing motions of things that they would normally do, but they have no meaning at the moment. Automatic obedience is going to be responding in a robot-like manner. Just, there's really no thought. They're just yes and agreeing to everything. Waxy flexibility, we can have, that is where they sit in a position for a really long period of time. We have stupor, which is that motionless, coma-like status for a long time. Negativism, which is pretty much playing the opposite game, doing the opposite of what's said. I tell you to stand up, you sit down. I tell you to sit down, you stand up. We have echopraxia, which is mimicking the movements of others. So echo, repeat, praxia is movements. We have catatonia, which is that decrease or increase in the amount of movement somebody has. Sometimes we can get muscular rigidity, and limbs may get to the point where they stay in a position wherever they're placed. We have that motor retardation, which is that slow movement. And then we have impaired impulse control. This is where safety comes into effect, because we don't really have, there is nothing to stop us from doing things that could hurt ourselves, because we don't have that impulse control. We usually have boundary issues. We have an inability to see where one person's bodies end and another begins. So they don't really know. They can't monitor, check their surroundings like they normally would. So those are just some behaviors. So the big ones that we're going to be talking about that you really need to know: these ideas of reference, persecution grandeur, being controlled, thought broadcasting, thought insertion, thought withdrawal, magical thinking, because that can lead to that impulse control. So let's jump down to that, the impulse control. So if they think they can put the shirt on and now they can fly, they won't have the impulse control to not jump off the roof and try to fly. Just kind of knowing what these words are in the alterations of speech and being able to match them with what a person's doing. Knowing these command hallucinations and tactile hallucinations are big ones. Illusions. the agitation, negativism, apraxia, and catatonia, and motor retardation with the impaired impulse control. Those are the big ones that I need you to know from like these symptoms, aside from the positive and negatives that we already talked about in cognitive. So this is just a picture that I really like that kind of sums up psychosis or schizophrenia in 5 little boxes. We got positive symptoms and negative symptoms, and cognitive symptoms. We can also have co-occurring problems. Typically with schizophrenia, we're going to have anxiety, depression, substance use, and suicidality. And then all of these symptoms alter big pieces of somebody's quality of life and their ability to function. So this is just a really good visualization of that. Okay. So we have phases of schizophrenia. We have the prodromal phase. This is onset. This is going to be that first psychotic break that's happening in that late adolescence, early 20s, where we start getting that mild changes in thinking, mild changes in reality, mild changes in mood, social deterioration, things like that. And a lot of times this predominant stage gets chalked up to something other than schizophrenia. It's just, oh, they're having a hard time. They're transitioning through this. They're having, they're turning into an adult. They're having trouble coping with life. And it's really early onset schizophrenia. Then we have the acute, which is where we have these exacerbations of symptoms. We start hallucinating. We start having flight of ideas. We start speaking rapidly, having the cling association. All of those signs and symptoms we just talked about, these things start worsening and revving up. So during the acute phase is usually when hospitalization happens, especially for our first time onset. We've ruled out all the medical things, and they get admitted, and then we get treatment, which we'll talk about here in a minute. And then during that time, we start having stabilization. The symptoms diminish, and we start getting our previous level of functioning back. And then we go to maintenance or residual, which is our new baseline. So they are never going to go back to the way they were before. There's a new baseline for normal for these guys. And then typically we're going to, if we relapse, we'll kind of go through these stages again. Relapse usually happens from that not believing that you have that illness and not taking the medications, or not taking the medications because you can't afford them, or anything like that, just like with any of our other social determinants of health. So now we have our treatments, which we're kind of going to go back into the pharmacological aspect of this. So a lot of this should be a refresher from pharmacology. We have our conventional or first generation, it could also be called traditional antipsychotics. Our typical ones with this is going to be chlorpromazine or haloperidol. Those are the two big ones that we see. There's some other ones in there, but those are the big ones I've seen through there. These medications have lots of side effects, which is why second generation is usually preferred, because first generation only treats positive symptoms. It does not treat negative symptoms. So these medications can cause extrapredominal side effects, those EPSs, that movement disorder, which we'll talk about on the next slide. The agranulocytosis, anti-chlorogenic effects. Remember that you can't pee, can't see, can't shit, can't spit. Weight gain and sexual dysfunction, which can lead to endocrine issues, such as menstrual irregularities, gynecomastia, and galactorrhea. So we'll have to notify the provider if any of these happen. That neuroleptic malignant syndrome is huge. Y'all can't forget about that. And that is going to be, it's just like malignant hypothermia from surgery, except from anesthesia, except for this is from an antipsychotic. You're going to get that spike in your fever, blood pressure is going to fluctuate, you're going to start sweating, heart's going to race, you're going to get that muscle rigidity, and you may lose consciousness and go into a coma. So typically our drug of choice for this, for the muscles, is going to be dantrolene, just like with hyperthermia, malignant hyperthermia. Cooling blankets, antipyretics, anti-seizure medications, antidysrhythmics, things like that. So everything about the treatment for neuroleptic malignant syndrome is symptomatic. So typically they go into the ICU and then they cannot restart antipsychotics for 2 weeks. So we need to, but really it's symptomatic treatment. We just treat the symptoms, and dantrolene is our big drug of choice that you need to know. They can also cause orthostatic hypotension, so you gotta, and sedation, so you gotta have those fall precautions. They can lead to seizures, especially in those with a history of seizures. So we want to make sure we are looking at that. It can cause dysrhythmias, so we got to monitor their EKGs in their heart. The sexual dysfunction, decreased libido. It can cause photophobia, meaning makes you more sensitive to the sunlight. And it can also cause liver impairment. So we got to monitor those LFTs and signs and symptoms of liver damage. So make sure you remember those. All right. So then we have our atypical antipsychotic drugs, also called second or third generation. Big ones that I see with this one is risperidone, quetiapine, which is your Seroquel, aripiprazole, which is your Abilify, and clozapine. The big thing that you need to remember is clozapine can still cause agranulocytosis. So they have to get that frequent blood work and monitor for signs and symptoms for infection. Okay. The rest of them have that tendency to cause weight gain that can even lead to metabolic syndrome and diabetes mellitus. Can also lead to high cholesterol and high orthostatic hypotension. We still get those anti-chlorogenic effects and can have agitation and dizziness and sedation or sleep issues. It can still cause mild EPSs such as tremor or akasia, but it typically has less EPS symptoms than our traditional. Okay. Big one I know I talk about in pharm, risperidone cannot be given to those with dementia. All right, so typical with first gen or traditional or conventional antipsychotics, we have our acute dystonia. The reason I highlighted this one is it is life-threatening because it spasms the neck, which can cut off the larynx. So that one is deadly. We have pseudo-Parkinson syndrome, so where basically they look like they have Parkinson's with those movements and shuffling gait, but they don't have Parkinson's. We have akasia, which is that restlessness, pacing, tapping, rocking, things like that. We got the where they fixed, that gaze is fixed upward. And then we have irreversible tardive dyskinesia. Some things that we're going to do for EPSs is lower the dosage. and give benzotropine, which is cognitin, or diphenhydramine to counteract the EPSs. And then I also highlighted neuroleptic malignant syndrome. While this is not an EPS or a movement disorder, I just wanted it to be on here so you could get those because you need to know the signs and symptoms of neuroleptic malignant disorder syndrome and how to treat it. So. Get nice pen. Dantrolene. All right, and that is it for EPSs. Great work.